Hello everyone, this is our presentation on addressing rural health challenges, access to primary care. My name is Brady Ahmed. Also working on this presentation with me is Michaela Fritz and Jessica Prenot. In this presentation, we hope to define the problem of accessing primary care in the rural population, explanation of the problem, goal of policy change, discussing our policy options and analyzing them, and then our recommendations for policy change.
So the problem is limited patient access to preventative care in rural Illinois due to provider shortages. Some of the root causes that lead to this problem are decreased incentives for providers to work in rural areas, limited training in rural areas resulting in bias, and limited healthcare facilities to actually work at. The problem statement is residents of rural communities in Illinois are faced with limited access to preventative health care services, thus increasing their risk for disability, chronic disease, and death. Who is affected? Rural Americans make up 15 to 20% of the U.S. population and face inequalities that result in worse health care than that of their urban and suburban residents. Rural residents must travel long distances to reach a healthcare provider. That means taking hours off for work, which causes delays or may even avoid care. In the state of Illinois, rural counties have higher rates of smoking, obesity, child poverty, and teen pregnancies compared to the urban counties. 20% of the total U.S. population lives in rural areas, but there's only 10% of physicians practicing in rural areas. This kind of gives you an idea of the scope of the problem here. In the state of Illinois, urban parts of the state have 90 doctors per 1,000 residents, while rural counties only have 45 doctors per 1,000 residents. 30.3 of the small and rural hospitals are designated in primary care physician shortage areas.
This is a map that shows the health professional shortage areas, specifically primary care health professionals in the state of Illinois. And as you can see, the dark blue areas are areas where the whole county is in a shortage area. The majority of those are dark blue, as you can see. There are actually 268 counties in Illinois that are designated as health professional shortage areas. And it's estimated that 586 providers would need to move to some of these designated areas to actually bridge the gap in healthcare needs.
The goal of this policy change is to improve access to primary preventative health care among rural populations in Illinois. This can be attained by focusing on increasing rural health provider education and incentivizing careers in rural healthcare, making them more enticing, and utilizing telemedicine where provider shortages remain, just to make sure that there's actual access to care. Increased access to primary care providers can help decrease healthcare disparities in rural areas and improve the overall health of the rural residents.
Our first policy option is telehealth. This is defined as the delivery of healthcare through technology such as computers, phones, or even apps. I'm sure, as most of you know, during the COVID pandemic, there was a huge uptick in the use of telehealth, and we're still seeing that trend carry on even, still. We found that it's really helped to manage patients and kind of break down those barriers to access. So the CDC, they actually have a program, the National Center for Chronic Disease Prevention and Health Promotion, and this endorses telehealth as an approach to improve rural communities' health. The theory behind that is that it can be utilized to reduce those access barriers based on living just a further distance from healthcare services. So obviously people in that, in the more country or rural communities, they're not surrounded by a clinic on this, on this street and a pharmacy on this street, so they have further distances to go for these services. So to be able to access healthcare through technology can really help them get that access that they need. Providers can also use telehealth to improve monitoring of chronic patient conditions. If you think about it, if a patient is able to upload or communicate their blood pressures that they're taking at home, then the provider can adjust their medications as needed without having them, drive or, try to come in from a greater distance away. Some further data in regards to telehealth shows that it can reduce readmissions by about 44%. It can decrease hospital visits by about 36%. With these decreases in admissions, it actually can reduce healthcare costs by about $10 million, which is quite a significant amount of money. So this is an image that's referring to the barriers to telehealth. Barriers to telehealth revolve around the digital divide. This can refer to anything from some of the racial disparities of internet access. For instance, 79% of the white population report having home internet, home broadband, as opposed to only 61% of the Hispanic population reporting that same thing. The digital divide also points out digital illiteracy. We often think about illiteracy being able to read, write, but there is a digital component to this as well. A lot of people in the older population, for example, they may not know the latest and greatest of smartphone technology, how to download this app, and how to use them. And they need that help and instructions on how to use it. There's also a very high correlation between smartphone usage and having a smartphone based on education level and income level. So that's what this image emphasizes, is that digital divide and some potential barriers that telehealth has in its implementation. So this is a slide that is going to expand on what we previously alluded to and talked about in the previous slide. So while most older adults have a device that has internet access, whether that be a phone, tablet, computer, we don't always utilize that in the same way per age group. So looking at, the top row of pie charts, so it's asking, in the past 2 weeks, have you used a smartphone, tablet, or computer to talk by video to a doctor or healthcare provider? When you look at ages 30 to 49, although the majority say no, we have 12% saying yes, and 5% are kind of reporting, I don't have that access. Ages 50 to 64, once again, it's a pretty low yes percentage, 1% less, but they do have a slightly greater don't have portion at 15%. But now if you look at that age 65 plus, that's a 32% don't have, so much greater than the age 30 to 49. And even if you look in that bottom set of pie charts, in the past 2 weeks, have you used a smartphone, tablet, or computer to talk by video to friends or family? You're going to notice in that age 65 plus, that don't have section is still 32%. And even in the yes category is 38% that have utilized that, compared to 71% and 57% of the younger age groups. So this theoretically could really alienate that older population who, either don't have difficulty utilizing, and arguably, potentially that age group could be that group that could utilize telehealth or that extra monitoring if they have access issues.
Policy option number 2 is the provider incentives. And the Underserved Healthcare Provider Workforce Program is administered by the Illinois Department of Public Health. This assists communities by recruiting eligible healthcare providers willing to practice in designated shortage areas in Illinois. Working a provider-based rural health clinic or hospital counts as a designated shortage area, and the IDPH will pay recipients up towards $50,000 for a minimum length of service obligation for a full-time care provider of 2 years. Barriers to the rural health incentives is that you have to qualify to be eligible. You must have loan debt. You must agree to accept Medicaid, Medicare, private insurance, and self-pay patients. You have to be willing to practice full-time or half-time in an approved medical facility in the shortage areas. There is a service commitment, like we talked about before. Full-time is 2 years. If you're part-time, it's a 4-year obligation. And there's only a 30-day window to apply for this incentive. So if you're not on your game there, you can miss the application process. That kind of limits availability. And then retention. There's a likelihood that these providers that are trying to get these incentives will leave rural areas after their commitment has lapsed.
The third option for addressing the gap in care for rural health would be to promote rural education among rural health providers and students. So there's currently a model that the National Center for Rural Health Professionals uses to recruit medical students from rural communities to actually return to practice in those communities or in another type of rural setting. There's this idea that a grow your own model is successful at retaining individuals who come from rural communities who will then choose to go back and practice in those communities. So the program involves an immersive clinical rotation in those underserved rural communities. They have add-on curriculum that is specific to the rural healthcare needs of that population. And there's a higher likelihood that they will come back and practice in those areas versus students who come from urban areas where there are more resources. They tend to stick to other urban areas. So this is a third policy option. This is just a graphic to show the rural education model. So if you combine the healthcare education specifically designed for rural communities, growing up within a rural setting, and then completing clinicals in a rural setting, there's a much higher chance of recruitment in these communities and retention of these individuals who are already familiar with the specific needs of rural health, and they're better equipped to deal with a more comprehensive care model where there aren't as many resources compared to urban settings. So this is our policy analysis table comparing the three policies of telehealth, provider incentives, and rural education. So we ranked policy number 1 as a medium public impact because of the limited internet availability for all patients. It's not always feasible for everyone to have internet access. However, it's a high feasibility because it's a relatively easy program to implement and manage. There are favorable costs depending on which telemed system the provider chooses, and providers can access systems as simple as Zoom, or they can pay for an entire system that manages those calls and waiting rooms. As far as the quality data about costs for telemedicine, there seems to be little data regarding the ongoing costs. For policy number 2, provider incentives, there's a medium public health impact because not all providers take advantage of this benefit. There's medium feasibility due to increased costs of the loan repayment programs. It's less favorable budget related due to the impact of provider retention versus the cost of hiring with little data to support this. There's favorable economic impact because it could help fill the provider shortage in rural communities. And then policy number 3 for rural education. We rated it as having a high public health impact because rural trained providers can reach a large population that could otherwise go without healthcare. There's a high feasibility due to programs in place at the local College of Medicine and rural track options. There's a favorable budget because the costs of clinical education pay off with higher provider retention rates. So what you're putting in, you're getting back from that. And there's more favorable economic impact because primary care providers who train in their communities are actually able to make a large impact on preventive community health.
After analyzing all of these different policies, they all have their benefits and their cons. However, we've decided that in first place becomes rural health education, second place, telehealth, and third place, provider incentives. So let's look at the rationale for why we ranked our policies the way that we did. So in first place, we put rural education. Now, education and additional training can take more time. However, that additional training is an investment. The goal of rural education is to take providers who come from these rural communities themselves, or providers that are invested and wanting to learn more about these rural communities that want to specialize and get more immersive skill set in caring for this population. Because the providers that you're gearing towards these rural communities are already invested and willing to learn and develop that skill set, we're going to see higher retention rates amongst those providers. They're going to stay in these areas a lot longer. Now, looking at our number 3 choice, provider incentives, it kind of gives us another look at this in the way of, with provider incentives, you have a reimbursement program that only gives you reimbursement for a few years. Also, the enrollment is only open for 30 days. So that's a very short enrollment period. It's also kind of a period that's fairly easy to miss. So if providers miss that enrollment period, they might, look at other options. But also, this really kind of emphasizes that this might be a short-term solution. It might get providers there initially, but it doesn't necessarily offer them that incentive to stay. So that's really why rural education bumped out those provider incentives. When you're looking at telehealth, now high-quality telehealth programs can be very costly. Also, if we're looking at patient internet access, is this a community that does have internet access? Or maybe they have internet access, but it's very slow. We don't have, that high speed, high quality internet access, which could also be a problem. And also digital illiteracy. What does this population look like? Is this an older population, younger population? Does this population have the capability to do what we need to do with telehealth? Because if your population cannot utilize it, it's not going to do you any good. So telehealth, although it could be a good supplement, it might not be the greatest solution on its own. And so for those reasons, we put rural education as our number 1 policy choice.
The impact of rural education as the policy would be increased access for rural residents of Illinois to be able to obtain preventive healthcare services. So ideally, this would also improve their chronic conditions and hopefully detect problems much sooner than someone who's not getting any preventive medicine. So hopefully we would also see a decrease in mortality rates related to those chronic diseases like heart disease, stroke, and diabetes. And we would also hopefully see an increase of medical providers who are better prepared to meet the needs of the rural communities that they serve. Some of the barriers to implementing rural education are that most providers practice in the areas where they train, or many do. And 99% of residencies are located in suburban or urban areas. So that's why these rural tracks are so important in retaining those rural prepared providers. Also, some other barriers include that students who may be interested in pursuing healthcare careers sometimes have limited opportunities for medical education prerequisite courses if they come from rural communities. So they're not necessarily well prepared for the entrance exams. Also, the average cost of a rural medical education program ranges anywhere from $350,000 to $600,000, and that's for about 15 to 25 students. So it can be costly, which can be difficult for smaller programs to handle. And there's also a reliance on funding from other sources beyond just the medical college or medical school. So there's a reliance on things like grants and funds from the state. So sometimes those can be barriers as well because the funds may not necessarily be available. Some of the ways that we could overcome some of those barriers are to work with local high schools and community colleges to promote rural healthcare at that level, and promote careers and be involved with curriculum development to get them in line for those tracks if they're interested in that. There's also the Rural Illinois Medical Student Assistance Program, which is a program that allows students interested in pursuing a rural track to have financial assistance and get them prepared for that track. There's, we all know about the Health Resources and Services Administration Loan Repayment Program to serve in a health provider shortage area. It's often associated with service for loan repayment and hopefully retaining those providers after even the commitment is fulfilled. And then also utilizing state and federal grants to fund education programs. In order to evaluate the policy results of the rural healthcare or education program, we would need to assess the number of rural healthcare providers available for preventive care, and we could look at that by looking at the provider to patient ratio for the area. We could also look at electronic health record data extraction to determine which preventive services are being ordered or rendered. So things like blood pressure screenings and cancer screenings for breast, colorectal, and cervical cancer. Also conducting a public survey to evaluate access to preventive health care services from the perspective of residents of that area in rural areas. And then we could also look at the percentage of rural track medical students who actually choose to practice in those rural underserved areas and how many of them are retained for beyond just their commitment that they have to serve for the program. So these would be some of the ways that we could evaluate how well the policy is working and make adjustments from there.
Thank you all so much for listening to our presentation. We hope you found it very informative. Please feel free to take a look at the next few slides at our references.